Thank you, Cyril. I am going to maximize my screen and I'm going to change the view here. Just one moment. Okay, you should be seeing this in the right mode now. Greetings, colleagues. My name is Brian Morales, and this is the Global Coalition to Address Synthetic Drug Threats Subworking Group 2.1, April 23rd, West Group session. I have a few administrative announcements to get us started. We will review the meeting schedule, the website, the initiatives, and the recommendations. I would like to start off by thanking you all for your partnership and participation over these many months of coalition meetings. The synthetic drug challenges, unfortunately, continue to worsen around the world, even during these months of our intense work. We've seen the continued emergence of new synthetic drugs and the rapid spread. And now we are seeing also national emergencies. We had a week and a half ago, the government of Sierra Leone, the president there declaring a national emergency over a synthetic drug called Kush. On the other side, we see a lot of redoubled efforts and enthusiasm to work together as a global community on this issue. At the Commission on Narcotic Drugs, the CND, that took place last month, there were many national statements by governments to address synthetic drugs, and also there was a lot of mention of the coalition as well. We also had two global coalition meetings, one on donor coordination and the other a general informational session. And then we also had side events that took place during that time. One of those side events that caught my attention was by the Global Initiative for Transnational Organized Crime. And they had a very interesting map that I'm posting on the screen here, the expansion of drug markets over the past 2 years. Those countries in red, where the illicit synthetics market has increased in severity, those in orange, where it remains unchanged, and those in green, the few green countries where it has actually decreased in severity. So this is very much an issue that is getting worse and that requires greater attention by colleagues around the world. So the meeting schedule now that we are sort of arrive at is the midpoint, the action planning and implementation of the coalition. We are going to be working in this halfway mark of the first year from April to July to see how we can take the great ideas that we had from November to February and bring them to fruition. And what does it mean to action plan and implement? What are we going to do over the 4 months of meetings? Well, we will be sharing national experiences. If you're interested to present on a topic and share your national experience, we invite you to click on the link that we're going to post in the chat that you see there on the screen in front of you, so that you can register your interest to participate, and to hopefully we'll be able to slot you in over the next few months. So please reach out to us if you'd like to present. Second, we'll continue our discussions on global initiatives and activities now as we start the operational phase. And then we will look at the engagement of other sectors. Can we involve civil society? Can we involve the private sector in the discussions as well? A fourth idea, which we don't seem to have a lot of time for, but we could always do alternative or additional trainings or events, are workshops or training opportunities for coalition participants. I want to just make a plug. UNODC has a wonderful training for policymakers on addressing drugs. So if you are new to the drug space or began recently or would just like to brush up, there is a great training that UNODC provides that hopefully we can make that available for participants of the coalition as well. Now I want to move on to what the process looks like moving forward. We currently have, I say 60 recommendations. We actually have 56 because in the East Group session, 4 of the recommendations in the last session were sort of collapsed into each other. So we have 4 fewer recommendations, but the text is all there. And we also have, so we're finalizing those recommendations in today's session for 2.1. And what we're going to look at from there is to then translate that into actions. What are the concrete measures, the different way to think about it, that you can take? We will be asking all of you participants to demonstrate your actions in support of these recommendations over the coming months. What do actions look like? Well, here are 5 examples. First, you could express interest in the coalition initiatives, the international organization initiatives that have been posted on the coalition website. They are located under the initiatives tab, which I will share with you in just a moment. And currently we have 115 initiatives across all sub-working groups. Please read and review those and sign up for as many of those, express interest in as many of those as you would like. Second, you might consider providing assistance, either financial or in-kind support, either to an international organization or to another country bilaterally as well. Third, you might adopt a domestic practice, a policy, a regulation, or a law. So this doesn't really count on international action or support. It's just simply sort of taking domestic action. Fourth, you might consider engaging and collaborating with the private sector in your country. And fifth, you might consider hosting a regional or global meeting of the coalition on a thematic area of interest. We were so appreciative of Italy's hosting of one of the Global Coalition meetings just in February, and thanking Simona Picchini and all her team for that work. If you would like to host a meeting also of the coalition on any topic of interest, we would very much encourage you to reach out to us at syntheticscoalition@state.gov, and we will work to see how we can make that happen. So we have actions that we are now encouraging countries and participants to register with us. We are looking at international initiatives that are beginning in this time period from April to August. And for the purpose of documenting achievements. And that is something that we're going to be looking at for the time frame of July of this year. All of these achievements that we have within this year of the coalition, we will be capturing within a year one report that we will look to publish in time for the UN General Assembly in September, when it will be released. And then from October onwards, we enter the full implementation phase, which is what happens during year two, where we intensify our efforts across all of the individual initiatives that we are now carrying forward. And from there, we will be looking at outcomes. And those are the sort of results of the coalition's work that will be published in a year two report that should show measurable progress in addressing synthetic drugs on a global scale. So where do you find the initiatives? On our website, it's that center tab that says initiatives. When you click on that, you will see the listing of 115 items. And then when you open one of interest, in this case, I opened up PICS, you can then see the description, the accomplishments, what are the activities, what will you achieve through outcomes, and then you should see the flags of all the countries that are currently participating. If your flag is there, but you are not participating, you are welcome to email the international organization. In this case, you see the hyperlink above, incb.precursors, and you can say, well, I'd like to join, this initiative. And if your flag isn't there, you could also join, you email and say, I'd like to join this initiative as a technical expert from my government. Make sure that you're included. Now, I have to share the caveat that just because you sign up for an initiative doesn't mean that there will be resources available necessarily. In some cases, resources are not necessary. In other cases, there is in-depth training and technical assistance where resources are necessary. Our team in the State Department, INL, are doing our best to meet the demands of the international organizations, but we certainly won't have the resources for so many initiatives. So we will also be looking at connecting with and partnering with other donors, other governments, to also support as many initiatives as possible in as many states as possible. Now I want to share with you an invitation to join another website feature that we have. It's a coalition discussion board that we launched last month. You should have received an email invitation to register an account and register a password. If you have not, or if you misplaced it, you can email us again at syntheticscoalition@state.gov, and we will send you a new link so that you can register for this discussion board feature. What does it look like? Well, once you'll notice that there's a login screen at the upper right-hand part of the screen. When you click on that, that'll take you to a login page where you'll introduce your username and password. And when you click on that, you will then see that you have now a profile at the upper right-hand section of the screen that you can click on, and a community tab that you can also click on there. When you click on the community tab, it'll take you to all of the sub-working groups that you have registered for, or you can add others if you're not registered for them. I'm going to click on 2.2 there. And when you click on 2.2, what it takes you to is a stream or a news feed similar to LinkedIn or Facebook, where you can say something. You can post articles or information or different reports that you've published. You can add images. You can also add content there, documents. And then at the bottom, here, for example, I've posted an article on Sierra Leone's national drug emergency that I shared with you all at the top of my remarks. And then at the bottom, you could see that we had our friend Donald Conte from Sierra Leone respond. Then I could respond back to him. There could be sort of a free-flowing discussion. So this is the plan for discussions and engagement outside of our monthly meetings. I encourage all of you to sign up and then to start sharing information there with other participants of the coalition. Now I want to move on to the final part of my remarks today, which are the recommendations. The recommendations have been worked on since March of last month, and we have some updates. So today we are looking at the updates since the last meeting, and then we'll have a discussion. But before getting into that, I wanted to share a chapeau that we've added to the top of the document, and the website, when we post it, will also include the chapeau. And that is the following. The recommendations herein are non-binding and for future government consideration where appropriate. They reflect the views of technical experts participating in the global coalition and do not reflect a consensus of governments or a single national position. Many of us participate in multilateral fora where we negotiate resolutions and texts. This is not that. This is not a national position. We are technical experts made up of governments, but these are not the national positions. These are our own. Governments are free to adopt one or more or none of the recommendations. And also, there are recommendations outside of these that could be developed and also implemented by governments in the spirit of the coalition if they are not put in here. So now I would like to move to the concrete recommendations for 2.1, and I will just read them one time around, and then I will turn it over to our co-chairs, Benoit Archambault and Charles Perry, to then moderate a discussion on that to see if there's any further edits or comments. And if there are none, then we will just move on to the next agenda items, and so they'll do that. So these are the recommendations. I will read them slowly for interpretation's sake, and then turn it over to the co-chairs. So we have recommendation number 12 under the topic of forensics. Improve information on drug consumption, origin of substances, patterns of use and harm by developing and participating in a global forensic network to integrate regional networks, supporting the development of and participate in regional intelligence networks of forensic laboratories, epidemiologists, researchers, academics, law enforcement departments, and community stakeholders, NGOs, to improve data collection. At a national or regional level, supporting forensic analysis capacity with a focus on assisting those in low-income countries by providing forensic laboratory equipment, mentoring, guidance and methods, technical assistance, sharing reference standards, and supporting laboratory accreditation. Assist in amending national legislation to exchange drug samples internationally. The next one, 13, on epidemiology networks. Facilitate and institutionalize sustainable and recurring non-personal data collection, analysis, and reporting systems through the establishment of national drug observatories and regional epidemiology networks, with the purpose of strengthening early warning systems and international data collection and dissemination platforms. For example, regional epidemiology networks, ARQ, DMP, EWA, Tox Portal, etc. 14, introduce and assess innovation of drug data collection techniques, such as wastewater analysis, artificial intelligence data collection tools, rapid situational assessments, web-based clinical screening tools, biological samples from health facilities, access to data visualization through training and technical assistance to provide greater clarity and precision with respect to drug use and trafficking. Now, recommendations 16, 17, and 18 were duplicative with those that came before it. So we looked at language. There were a couple minor items, and we incorporated those into the 3 previous ones. So we have the new 15, to create and strengthen early warning systems with new or reinforced work streams where appropriate to promote voluntary cooperation between forensic laboratories, national stakeholders, including the community, NGOs, health organizations, and researchers, academia, and to improve national, regional, and sub-regional collection and sharing of non-personal data to allow for real-time usage, including the development of mechanisms to alert emergency rooms and clinicians of new substances that are being detected through data from seizures and international early warning alerts in collaboration with emergency rooms and clinical treatment. 16, share non-personal health data, including information on potential overdose spikes that could inform timely intervention/prevention efforts. And these are the recommendations for 2.2. Now, I'll mention that the recommendation of the East Group co-chairs from 2.2 were to remove the distinction between 2.2 and 2.1, identifying that the recommendations in 2.2 were as relevant for 2.1 as for 2.2, and vice versa. And so they would just like to say that all of the recommendations within Working Group 2 are within the spirit of and use for all members of Working Group 2, and therefore we should erase the distinction between 2.1 and 2.2. That could be also a point of discussion. Also, I won't take up time now reading the 2.2 recommendations that you see on your screen, because we will review them in 1 hour's time when we have that sub-working group. But at this time, I will stop sharing my screen and turn it over to our co-chairs. Thank you for your patience, everyone, and looking forward to the meeting today. Benoit and Charles, over to you.
Thank you very much, Brian. We're going to be focusing on the 14th recommendation, which, as Brian has said, is on innovative approaches. And we're going to have 2 presentations today. Firstly, on the wastewater analysis, and then on rapid situation assessments. And what we're going to do is have the presentations and then have a discussion of each. And what we'd really like in the discussion is for those of you who are participating to really engage with it and think about whether it might be something you would like to implement in your own countries if you don't have them. So we're going to start with the wastewater, and I'm going to hand over to Benoit, who will introduce our first speaker. Thank you.
Thanks a lot, Charles. Yes, we are very proud of our first speakers today, which is João Macias. João is an epidemiologist graduated from the London School of Hygiene and Tropical Medicine. In 2004, he joined the European Monitoring Center for Drugs and Drug Addiction and the Public Health Unit as a scientific analyst, responsible for epidemiological indicators, prevalence, and patterns of drug use, addressing topics such as drug survey, air testing, drug checking. He also worked at the United Nations of Drugs and Crime in Vienna as a drug market analyst. So without further ado, João, the floor is yours.
Hello, hello, and good afternoon from Lisbon. And many thanks for inviting us to present our work on wastewater. Try to share my screen now. Okay, I hope you can see it now.
We can see your screen. Go ahead, please.
Yeah, great. So what I want to present today is a very brief summary of how we work with wastewater-based epidemiology at an EU drugs agency, and how we collect data for more than 100 European cities each year. Very bluntly, wastewater-based epidemiology for us is a complementary method that measures patterns of drug use. So the drugs that have actually been used, And we work together with an international network called SCORE. So we do not do ourselves the analysis, wastewater, but we do collect every year data for 1 week, samples for more than 100 European cities. How this all started for us. I mean, when preparing this, it goes back to 2008, where we had our first meeting and developed a technical manual, trying to see how we could apply this method across Europe to complement data coming from traditional surveys. I have to say, I mean, internally, we found this as like an eureka moment, and it was a potential game changer for us in terms of the ability to produce almost real-time information on the quantities of different drugs used at city level. Then, of course, at the same moment, and I think this is also important for national level, for the countries that might want to do this in the future, we had some considerable technical and political skepticism. We had a lot of a lack of understanding on the methods. It's always like this, fear of the new, mostly coming from people that were already doing drug surveys and people that did not like testing on principle. There was a lot of exaggeration of the technical problems and limitations around the method, so that we had to work a bit on that as well. On the same time, from the side of those doing wastewater analysis, so the researchers in universities, there was also a bit overselling the method as a way to enter, let's say, in the field, and some ethical concerns and operational uses that we had to define from the beginning. As I mentioned before, the way we thought about overcoming these barriers was to develop quite a close relationship with this international network, SCORE, and to develop a collaboration by setting up some standards and accreditation work for the different labs that participate. We had some European funding to prove the concept and also to develop a bit the methods around the analysis for different substances. We clearly had to make a distinction between what we call operational and surveillance activities, and we developed together with the SCORE network some ethical guidelines that are published on our website and can be easily downloadable. From the beginning, we thought it was important to communicate and do a co-production with those doing actually wastewater analysis, always emphasizing that this is a complementary method that would not replace any existing methods measuring drug use. There's no need to oversell the method because, I mean, the results coming from wastewater-based epidemiology talk for themselves, so there's no need to oversell it. I think it was recognized that the benefits of using different methods and different data sources that could complement each other, and very important, that people doing wastewater epidemiology should also work together with drug epidemiologists. And I think us as an European Union Drugs Agency, we work as a platform for make different professionals at national level to work together and also to promote the results in a way that can inform different stakeholders. Very important for us how to communicate the results coming from wastewater epidemiology. We created on our website a page on the do's and don'ts on communicating results. I mean, I won't read in detail here, but I think it's very important that if you decide to do this at national level, that you know what the method is for and what it does not do. And it is a robust method, but it has its own limitations. Also, we have developed the frequently asked questions around this tool, also available on our website. What is wastewater-based epidemiology? What are the ethical considerations? How can it be applied for different types of drugs? If it can be done in events like music festivals, if it can monitor drug production. So you can find all this information on our website. Every year, around March, we publish the data on our website with a data visualization tool. All the data that we collect is publicly available, and you can look for the different cities. For the first time in 2024, we published also data from outside Europe. So now we have also cities from the US, Brazil, Chile, but also Australia, New Zealand. So feel free to jump in our website and you will have access to data on cocaine, cannabis, amphetamine, methamphetamine, MDMA, and ketamine. When we do our analysis and publish our scientific reports, we tend to present the data from wastewater always alongside data from our indicators. This is just an example on data from MDMA, where we talk about the prevalence of use. So data coming from national household surveys, where we talk about the millions of people that have used the substance. Then we move on into wastewater analysis to show recent trends at city level. And then we combine with data coming from law enforcement on production, but also on the content of MDMA tablets and the purity. I mentioned this before, but I think it's very important to stress. We consider it alongside a number of other complementary methods, like, for example, wastewater, like web service that reach people who use drugs, on data coming from hospital emergencies, but also data from also city level on used syringes. So we analyze for the residues left inside needles and used syringes, or data coming from drug checking services in Europe. To conclude, and also to respect the time given, I mean, as with any other methods, wastewater has a lot of strengths. It's not subject to bias, so people are not asked. So we do actually analyze wastewater in treatment plants, and we look for the true spectrum of drugs used. It really has timely information and gives us a lot of information on geographical and temporal trends. As an example, we can have the levels of drug use in a city for the different days of the week, which we do not get from any other data source. Once it's established, it's relatively inexpensive to carry out. Once you have the labs in place to do the analysis, it's quite straightforward. On the other hand, it also has a lot of limitations. It does not tell us anything about the prevalence of use, so it does not tell us about who is using it, how many millions are using a specific substance. It doesn't tell us anything about the patterns of drug use. So for example, routes of administration, the frequency of use. It gives us city level data, but not which we can't extrapolate to a whole country. And still, we only have data for 5 or 6 substances, and there are some uncertainties around using it, for example, for heroin, but also on how to calculate back the amounts used in a given city. To conclude, lessons learned from our side, and if we would like to keep, as I would say, take-home messages as factors that can influence and facilitate the adoption at national level or international level. Once you have it in place, clearly state the limitations. Do not oversell the method. Do it at different stages. Do a developmental approach, like we did, supported by different EU research funds, so that you can give small steps in order to succeed. The way you communicate results, the communication strategy is key. Again, emphasize as a complementary method and not something that will replace all your other research methods in place. Very important, rely on ethical and quality assurance guidelines. One thing I did not mention, very important, every year, us with the SCORE International Network, we do quality control exercise between all the labs that participate with monitoring data, so that we are 100% sure that the data we collect is comparable. And each lab that participates is obliged to undergo this quality control exercise. At the moment, the SCORE network is quite big, with more than around 40 countries in the world, covering a lot of cities. So feel free also to join if you would like to do wastewater in your cities. And last point, presenting the data in a way that is easily accessible and that it can be used by different stakeholders in your country. And I think I would like to finish on with this one. So thanks a lot for your invitation and for us to show our work around wastewater. And I'm happy to reply to any questions you might have.
Thanks a lot, Joao. Very, very interesting. I know that we have a short period of time, but we're going to take the opportunity because you're there maybe to have some questions from the floor. So normally, as always, we start with the co-chair, Sibona, Grant. Any question, anything to comment you had for Joao's presentation?
Programs and policy in South Africa and in the region. His work focuses on the intersections between infectious diseases, determinants of health, and rights, with a particular focus on substance use and harm reduction. He's also a technical advisor for an organization called TB HIV Care. He's a researcher at the University of Pretoria's Department of Family Medicine. He does consultancy work locally and internationally for networks of people who do drugs. And his presentation today is on using rapid situation assessments. So over to you, Andrew. Thank you.
Great, thanks. Wonderful to be here. So I think it's an opportunity for me to provide an overview of different methodologies that are more field-based and taking this approach of rapid activities that could be done. And I'm going to speak about some broad different methods that are used in various contexts and give some examples that I've been involved in the South African context, and just end with some conclusions. So when we hear the term rapid assessment, it's also rephrased as rapid assessments and responses. And it's a methodology that's been around since the early 2000s, drawing from social science and public health, that really looks at using a methodology that enables us to detect the extent and nature of a social or a health problem and really provide suggestions of how things can be addressed. Rapid assessments are unique in that they often are focused on using a method or a combination of methods that are appropriate for a specific problem, for use in a specific context. They are designed to be rapid and for efficient resource use, and ideally are tailored to provide evidence for action. And it should also be part of the action, evaluation, reformulation approach. This is somewhat different to other types of assessments, which may be broader in nature or may be more non-specific, or that may place greater emphasis on rigor and generalizability, and the resulting assessment requiring greater resources and also taking longer time periods to plan, to implement, and really to take action. So the overall approach is in light of some issue that's been identified. So it could be in the context of an emerging synthetic substance or another substance in a context, from whatever mechanisms, from a community alert, from global awareness, and then importantly involving a process of consultation and identifying individuals who can be involved in the design of the rapid assessment, then doing an implementation in response to the key findings from the implementation, and then evaluating how effective that was to then provide that information back to the people who are consulted and ready to make course correction and improve whatever the implementation intervention was. So when thinking of synthetic drugs and assessments, there are a range of different perspectives to consider. And they could be along the supply chain, depending on the substance of interest, for things that are coming from organic substances or things that are synthesized in a laboratory, Also, there could be assessments that take place to assess the dynamics of trafficking through different methods, through different geographic locations, also to the dimensions in where the activity is taking place, either virtual or personal networks of drug market components, or even among people who use drugs themselves, or other stakeholders who might be involved, policymakers, service providers, influencers. In addition to the perspective, it's which components would we be of interest to focus on that could relate to some of the shortfalls of wastewater analysis, as mentioned earlier. Using a rapid assessment, we could focus specifically around drug use practices or on specific health considerations or aspects of the economic dynamic or population size estimations or the specific chemical compositions of aspects or other indicators, for example, mortality, or a combination of these indicators to be included for assessment. And also what is nice with this approach or conceptualizing it is the utilization of a range of methodologies. So it could involve qualitative work, either interviews or focus groups. It could draw on some of the quantitative data, as we've heard about wastewater analysis. It could be triangulation with the rest statistics. It could be the use of more qualitative mapping, which could be digital. It can be done in real time. It can be at a local level. It can be at a regional level. It could be the triangulation of available data, which could be programmatic. It could be surveillance, depending on the context. It could rely on the extrapolation of data to different contexts. It could involve observations, and it could also involve quantitative surveys. In addition to knowing the methodology, it's also this concept from public health, this idea of the population, of who is it that we would be looking at gathering information from. And this could be people in a specific city or in a country or in a region. And it could relate to people who use drugs. It could relate to insight from policymakers, health or social service providers, law enforcement, but also people who are engaged in the drug trade. So sellers, merchants. But we know that from within the whole population, it may not be practical to do a census to count everyone or include everyone because of a range of factors. So from an efficiency perspective, we would then select a sample of individuals to be involved in the assessment. And depending on the specific methodology and the intention and the resources available, a range of sampling methods could be used. We could opportunistically sample people because that's what we're able to do. Or if we have a sampling frame, or we have some of the new methodologies to approximate random sampling, like respondent-driven sampling, we're able to enroll people that will give us generalizable results. Or we may be doing purposive sampling, which is identifying specific individuals and gaining their unique perspectives into the area of work. There are some important good principles of practice from the work that I'm involved in. It's critical that the people who use and that have lived and living experience of drugs are integrally involved in the conceptualization of the issues of developing the implementation and evaluation and interpreting the results. Of course, this should be done to ensure that the benefits of the planned work outweigh the risks, and that it's done in a way that these individuals are protected, and that the approach is tailored to the local context, and that a range of stakeholders are appropriately involved. And one of the good practices that can evolve from a rapid assessment is to identify how the methodology can be improved over time, and potentially aspects that can be integrated into an appropriately resourced surveillance system. So from our context in South Africa, middle income setting, some of the aspects will be more feasible to continue as part of longer term surveillance than others. And this could also identify an issue that could be followed with more rigorous information detection. So just a recap why thinking of South Africa as a geographical area and a political area is of importance. We know where we're placed, in the southern tip of Africa along a range of the drug trafficking routes, maritime routes. We know that a large quantity of opioids and stimulant drugs destined for the European markets, but that come from Asia or from South America, travel through South Africa. We also know that South Africa has got one of the largest African markets of drug consumption. And we also do know that there is the technology and the expertise to manufacture synthetic substances. So it's an important area to get a sense of what's being done. So the rapid assessment response method can be adapted in a range of contexts. These are just some examples of some of the work that I've been involved in over the past decade. In the early 2010s, there was very little data on injecting drug use in South Africa. And with the United Nations Office on Drugs and Crime and other development partners, we used an adaptation of the rapid assessment response methodology to get a sense of what was happening with drug injecting, drug risks, and the HIV burden among people who inject drugs. This involved focus group discussions, interviews with stakeholders, as well as people who use drugs, and doing a biological survey, and then triangulating that information and validating it through consensus workshops. And from using that initial information, provided some baseline data to inform our national strategy around HIV, and also provided the motivation for harm reduction services. A more recent methodology, which I was involved in, used people who use drugs to be doing all the field work. It was an adaptation of the rapid assessment response to also then include sellers of drugs and merchants. So it was done across 9 cities, and this was one of the countries, and it was done in several countries across Southern and Eastern Africa, where there were focus groups of people who use drugs. They did then field work in the community, speaking to their peers, gathering information around the drug market, the costs, the volumes of use, the directions of flow. We also did interviews with sellers at different levels of the market to get a sense of the quantities and the volumes and the costs. And then this information also helped us to generate some local population size estimates. And then through the process of triangulation and Delphi methodology through consensus workshops to come up with some estimates for extrapolation, which, while with several limitations, at least gave us new insight into the market and a starting point where with Bayesian methods, we'll be able to improve the accuracy of our estimates. More recently, these papers are under review for publication. It's been work done with the University of Bristol to see how we can use existing programmatic data to rapidly assess detailed aspects that we might not have a good sense of. So on the table on the left, that's data that's come from our harm reduction programs, which have been funded by global development partners to focus on HIV prevention for people who inject drugs, with very strong monitoring and evaluation systems, but generally have not had the time or the expertise to do more detailed cohort analysis. And through that, we've been able to identify very high HIV incidence despite the harm reduction programs in place, and to give us added information of why the harm reduction services need to be scaled up. Similarly, on the right, you can see how there's been an analysis of multiple household surveys. This is data that comes from the HIV surveys that have been done over several time points, and then by pooling the analysis to see what the trends over time have been among adults participating in the household surveys, to give us an assessment of change over time. And really, these are just examples of using secondary data that is available as part of the toolkit to do this kind of assessment. So as we all know, particularly people on this call, that drug markets are dynamic and the patterns of use are very dynamic. And the use of innovative methodologies that can be rapidly addressed and can involve multiple methods can have lots of utility, but it is very critical that people who use drugs are involved in the planning and the implementation and the interpretation of that work. And really, they should be linked to some kind of intervention that's going to benefit those individuals who use drugs, as well as society more broadly. And that this methodology is well suited for synthetic drug surveillance. We haven't used it specifically around novel substances, but did use it around methamphetamine, cocaine, and heroin in the Southern African context. And South Africa is well placed because of all those market dynamics. And there is a growing expertise of innovative approaches and also working with community researchers to do this kind of work in our context. So thanks very much. Back to you, Charles.
Thanks, Andrew, for covering that. So we've had a lot presented there, but we have a few minutes left for discussion, and I'm going to go back again to Simona and Grant to see if they have any input before we open it up to others.
Good afternoon, Andrew. Just a very quick question. If I understood well, this program was implemented only in South Africa. Was it also implemented in other parts of Africa, in other parts, for example, of low-income countries of South Asia? Are you trying to do these? Did you do these?
So this methodology is not new. It's been around since the early 2000s, mostly promoted by UNODC and UN agencies in countries that have used those data to inform their health programs. So there have been several countries in Southeast Asia, for example, that have used rapid assessment response to inform their harm reduction programming. Vietnam is one of them, but there would be several others. The methodology of working with drug sellers, I was involved in doing that. That included Eswatini, Malawi, Tanzania, and Lesotho. So that was part of a program that was funded through the Global Initiative of Organized Transnational Crime. So it's a methodology that can be adapted. Currently, it's not part of a global program, but I think the value is that the methodologies and tools are very adaptable, and there are some key things that can be collected and used in a range of contexts. And ideally, if you can include sample analysis, so that's something that also I didn't speak about, but in South Africa, we're working with people who use drugs to gather drug samples from them rather than from the police and analyze those samples to get a sense of what people are using. To date, it's focused on opioids because that's of interest, but we could very easily use that methodology for novel synthetic substances.
Great, thank you.
So with the global coalition, it can be implemented in a global way, no, Charles?
Very much, thank you. Thank you for that question and the response. Grant, do you have anything to ask at this time?
I don't, thanks, but thanks for the presentation, Andrew.
Great, thanks. I mean, I first used it looking at sex workers and injection drug users back in the early 2000s. And the CDC, the US Centers for Disease Control, had used it in their research on HIV. So I think it's got quite a long history and it provides very fresh, useful data. So thank you for sharing that. Let's see if we have any questions from our other attendees before we end off. We've got a couple of minutes. You've all been very patient listening, and I'm sure some of you maybe have some questions. Just raised your hand. Okay, Andrew, I'll ask a question then. What do you see as the sort of major challenges to using this approach? Does it require a lot of training, expensive analysis? You need skills in analyzing qualitative data. If you're doing qualitative, any just ending comments?
So I think it's actually one of the lower resource requirement methodologies. So from a surveillance perspective, CDC and PEPFAR rather suggest what are called biobehavioral surveys that are much more rigorous and much more resource intensive. So you can do a rare, quick and dirty and get good enough information. And I think you are able to work with collaborating partners to address maybe the technical components of the data analysis. And because then the information can move, but the fieldwork can be done very simply. So I think it's very easily done. There aren't a lot of barriers. It is important to get ethics approval. And I think that's also sometimes a hiccup that can take a while, but there practically are very few barriers to implementation.
Thank you. Let's end off there, but I'm going to ask Benoit to say what's going to happen probably in our next meeting next month.
Yeah, thanks a lot, Charles. So today we focus on the recommendation 14, I think. So next month, we don't have the exact date, but end of May, we'll be focusing on another recommendation. I think it's the 13, which is the
21st of May.
Okay, yeah. So strengthening forensic analysis of synthetic drugs. So next meeting, I'm going to focus on that. So thanks everyone for your participation. So keep trying to look at the web page, the coalition web page. All the information are there. The record will be posted there as well. So talk to you in a month with another recommendation. And thanks to the presenters, Andrew and Joao. Very nice job. Thanks a lot, everyone. See you next time.
Thank you all so much.
Yeah. Thank you. 22nd of May, I believe. Yeah.